The debate that I've had with Evangelos Tarpos, chaired by Arnon Nagler, so Evangelos Tarpos from Greece and Arnon Nagler from Israel, was about two major concepts we struggle with in the real life with our patients. The number one was we demonstrated preclinically and clinically that the more you give a treatment continuous approach, the better it is for patients. But how much is this really feasible, and how much evidence, scientific evidence, are there to convince everyone that in any situation this is the right approach? And I think we agreed on, at the end of the debate, of course, we agreed on that continuous is key. Continuous until progression certainly makes sense. But we agree that for certain group of patients, this is hardly being able to be conducted. Frail patients. We also agree that even if you go into progression, the disease will still develop mechanism of resistance. We agree that it has a certain cost impact and a certain side effect, potential side effect impact, depending on drugs. Some drugs more than others. Although the novel generation of drugs seems to have less and less side effect profile issues on a mid-term run and a long-term run. So again, the debate ended up with the conclusion that continuous is key, but we agree it needs an effort to be run because for the patients in general, fixed is better. For the quality of life and the cost of treatment, fixed is better. But for controlling myeloma, continuous is definitely better. The second debate was about triplet versus doublet regimens. Again, similar to the first debate, in the real practice, if you go for triplet-based regimen, you certainly have the conviction that you're going to control better the myeloma, but you're also increasing a certain burden for side effects, a certain burden for cost issues, a certain burden for quality of life of the patients, and also a certain burden in terms of trying to be innovative in the kind of regimen you're going to propose to the patients. So I debated for triplet while Evangelos debated for doublets. I think we agreed that for the majority of the patients, triplet is needed. Triplet is not that difficult to manage. And at least for the first or second, potentially third line, you certainly can think of different triplets you would come up with to treat the patient. But we also agreed that they have situations where certainly a doublet is much better and safer and would be clearly recommended to patients. Obviously, the frail patients comes first at mind. In non-transplant eligible patients, in certain situations, especially standard risk patients, you may want to start doublet and only contemplate a triplet-based regimen if you had the feeling that the patient would not benefit much from doublet, but starting with a doublet would not necessarily be an enormous mistake there. Now, for any situation where you're high risk or clearly very fit patients, it's with the drug we have today, at least in the initial phases of the treatment, first line, second line, and potentially third line, you would certainly recommend a triplet and not to play around with a doublet first to see how it goes.